So, good evening, everyone, and thank you very much, Bharam Sriram, for giving this opportunity to create awareness on aplastic anemia in society. And we all know that aplastic anemia means that there is a decrease or absent production of hematopoietic stem cells. So, hematopoietic stem cells are the cells which produces the all other hematopoietic components like red cells, white cells, and platelets. So when the hematopoietic stem cell production is affected, uh, there is decrease in red cell production as well as white cell production and platelet production. When only two lines are affected, we call it as a bicytopenia. But when all three lines are affected, is pancytopenia, and maybe it can be aplastic anemia also. It is a rare disorder, and the incidence of aplastic anemia in India is around 4 to 6 cases per 10 lakh population every year. So, which is not a common disease, but it is very important disease because if this disease is diagnosed early, then it is a curable disease. And early diagnosis is very important for uh, better prognosis of this disease. So, usually patient they present with low hemoglobin, tiredness, then recurrent infection, or sometimes when the platelets are low, they can present with the bleeding or ecchymotic or fatty spots, black spots on the skin. So this is the usual presentation, and with this presentation, patient may go to physician, and then when CBC or complete blood count is done, and we came to know that patient is having pancytopenia or all three series are reduced. So aplastic anemia is a very important disease as far as hematological disorder concerned. It is not a cancer, but the most of sign symptoms are like cancer. And as I mentioned, the prognosis, if it is diagnosed early and if treated early, the prognosis is very good. Now we are having very good treatment available for this disease, which we will discuss now. And for this, I am having a very expert panel, very expert hemato-oncology of the country. First of all, I will introduce Dr. Kasi Viswanathan T, who is expert in hematology and bone marrow transplant and is working as in Meenakshi Mission Hospital, Madurai. And then we are having Dr. Nitin Sood from the north. He's vice chairman and medical oncology and BMT specialist in Vedanta, Gurugram. And then Dr. Avinash Kumar Singh, who is director and head of department hematology oncology department in Bharat Hospital, Patna. So I will just ask the question and pass to them, and they will give their expert opinion and expert view on this. And we want to create awareness regarding aplastic anemia. So these patients, if diagnosed early, then they can get a proper treatment. And as I told you, then if diagnosed early and treated early, then it's a curable disorder. So my first question will be to Dr. Kasi Viswanathan.
Hello,
Why?
sir.
Yeah. So I just can you say what is aplastic anemia again and why it requires a different approach than other hematological disorders?
Yes, sir. Sure, sir. Good evening, everyone, sir. Good evening to you, sir, and to my fellow panelists. It's aplastic anemia is a serious disease, so that we have to know first what it is. So we can consider our bone marrow as a factory which produces the blood cells of our body. So it is a breakdown of the factory. So there is literally reduced production of all the blood cells, namely the red blood cells, white blood cells, and the platelet count. So this is a bone marrow failure. So patients have reduced blood counts, and they have symptoms related to the reduction of the concerned blood cells. If the RBCs are very low, they feel very tired and they are very anemic. They don't have any energy. If the WBCs are very low, their immunity, body's immunity is very low. So they are prone to develop infections even a simple infection can become a serious life-threatening disease problem. And if the platelet count is very low, it will lead to bleeding manifestations. It can be simple bleeding manifestation in the skin or in the oral cavity. Sometimes serious bleeding, like bleeding in the urine or in the stools. Or the most dreaded complication is the bleeding into the brain. So they can suddenly have a unconsciousness or severe headache and vomiting. So this is a brief introduction to aplastic anemia, which is, to simple layman term, we can say bone marrow failure.
So,
Over to Dr.
Doctor
Sandip, sir. Yeah.
Dr. Kasi, do you think all the present with such severe sign symptoms, or some there may be some mild sign symptoms and some present with present with severe complications?
Yeah. Initially they can be very subtle symptoms. So they can be just having tiredness and lack of energy, and they when we do a blood test, we will find a very low hemoglobin and mildly reduced other cell lines. That the WBC and the platelet might be slightly low. Not all patients present with very severe symptoms. Some patients present with very severe symptoms, some present with mild symptoms. So basically the diagnosis depends on the further investigations and diagnostic test, which we will discuss in the further discussion.
Yeah, I rightly said now. So, Dr. Nitin Sood, so how different is diagnosing and treating aplastic anemia versus other hematological disorders? So, what is the difference, and how do you differentiate in diagnosis between aplastic anemia and other hematological disorders, including malignant disorders?
Yeah, sir, good evening.
Good evening.
I mean, aplastic anemia, as we earlier said, is a condition where the bone marrow fails and doesn't produce the cells that the body needs. Uh, like all hematological or blood problems, the diagnosis is a complex mixture of blood tests and bone marrow tests and other scans. It may need different specialists. And for example, it may need hematologists and pathologists, even some radiologists sometimes to make a proper diagnosis. But the difference is that we would find all cell lines, meaning the red cells, white cells, and platelets, low in this condition. And unlike other cancers of the bone marrow, we don't find any infiltrate in the bone marrow. So when we do a bone marrow test, we see that the factory is literally shut down. We see that the bone marrow is full of fat cells, and very little blood cells are being made, and that clinches the diagnosis. But unlike other problems, aplastic anemia sometimes is also a diagnosis of exclusion, because we have to rule out other problems before we make a diagnosis. And other problems meaning, or we may need special tests like karyotyping or flow cytometry to rule out other diseases, to rule out things like PNH, which might be hiding below the aplastic anemia. So complex tests may be needed. Several other diagnoses may need exclusion, especially toxic or viral exposure, autoimmune exposure to the bone marrow damage, and multiple specialties may be needed. So it's a complex diagnosis.
So, coming to Dr. Avinash Kumar Singh, what is your opinion how it is management of aplastic anemia is different compared to other blood disorders, or what difference do you think is between aplastic anemia and other leukemias or other benign hematological disorders?
Yes, so good evening, sir, and good evening, everyone. Uh,
Yeah.
am I audible? Yes.
Yes, yes, audible.
Yes. So, as we have discussed, aplastic anemia is a rare disease and it's a type of bone marrow failure. So, uh, it needs a specific treatment. While other hematological disorders like leukemia nutritional deficiency, or other hemolytic anemia, they need different types of treatment as per their primary reason for cytopenia. So aplastic anemia, whenever we diagnose, we look for cause of aplastic anemia, whether it is acquired or it is inherited, because the managements are different. Then we look for severity, whether it is very severe aplastic anemia, or it is non-severe aplastic anemia, because the very severe and severe, they have fatal consequences. So we need definitive treatment sooner. In younger patients, we may have to go for hematopoietic stem cell transplant, or if suppose donors are not there, matched sibling donor or mud donors are not there, then we may have to give immunosuppressant combination like ATG, cyclosporine, and thrombopoietin receptor agonist combinations. If it is inherited aplastic anemia, then definitely we have hematopoietic stem cell transplant as curative treatment. If there is no donor, then we may have to depend on anabolic steroid. As well as in both inherited and acquired, we have to give best supportive care that includes blood component therapy, therapy for infections, uh, precaution against infection that we have to follow. So aplastic anemia needs separate specific treatment, while other hematological disorders like leukemia, lymphoma, or other hemolytic anemia, they need different types of treatment. So best supportive treatment can be common to all hematological disorders, but there are some definitive treatment which are different.
So you rightly said it's a very specific disorder and needs a very specific treatment. Uh, so I will ask Dr. Kasi Viswanathan that what are the causes of aplastic anemia and how will you differentiate congenital aplastic anemia to compared to acquired aplastic anemia? So how will you differentiate and what is the etiology of acquired aplastic anemia?
Sure, sir. As we all discussed, aplastic anemia could be due to idiopathic reason, that is unknown reason, or acquired cause, which is 80% of the aplastic anemia. And 20% of patients with aplastic anemia have a genetic disease, that is inherited disease. So that leads to bone marrow failure. So it is very important to differentiate whether a patient with aplastic anemia has a genetic disease or a acquired aplastic anemia, because the treatment modalities which we will be discussing subsequently will be different. So to diagnose aplastic anemia, once we do the bone marrow, we do additional test, genetic test, from which we come to know whether the patient has a inherited or a genetic disease. So there are few causes of inherited aplastic, like Fanconi anemia, dyskeratosis congenita. These are the two common inherited aplastic anemias. These can be diagnosed with help of additional cytogenetic test called stress cytogenetics and whole exome sequencing, which we can do a genetic diagnosis of these patients. It is very important, especially when we are dealing with the younger age group, which is up to 40 years of age. Inherited, that is genetic aplastic anemia, can present even in the age of 40 years. So whenever we diagnose aplastic anemia less than 40 years, we should make sure that we are not dealing with genetic diagnosis of aplastic anemia. We can have some clues that it could be acquired aplastic by detecting a clone called PNH clone by flow cytometry testing of the peripheral blood. If it is positive, we can take it as that it is a acquired aplastic anemia. If it is not, if it is negative, then we should make sure we are doing stress cytogenetic and whole exome sequencing to make sure we are not missing out on a genetic aplastic anemia. So what
So
else is the question, sir? Is that uh,
no,
does that
so
answer the question?
yeah, you have answered the question, and I think that means that we have to do bone marrow aspiration, refined biopsy, and followed by cytogenetic study, stress cytogenetics, and then NGS study. So that is very important for deciding the cause of whether it's a congenital or acquired aplastic anemia. So my next question to Dr. Avina Singh. So how critical is laboratory hematology and accurate interpretation of the results in confirming aplastic anemia? And you can also enumerate what investigations are to be done for the diagnosis and further management of aplastic anemia.
Yes, sir. So for aplastic anemia diagnosis, the role of lab hematology is very important. And as our panelist has said that aplastic anemia is also diagnosis of exclusion. So all causes of pancytopenia has to be excluded. So we start with CBC that will show pancytopenia. A good peripheral blood smear examination is very important. It should not have atypical cell or blasts or any parasites should not be there, which can cause pancytopenia. Then reticulocyte count is important because it's one of the severity criteria. Reticulocyte count comes. So CBC, peripheral smear, reticulocyte count is important. Then comes the bone marrow examination. So bone marrow examination is never only bone marrow aspirate. Many a times patient they come with external puncture and saying that it's hypocellular and bone marrow biopsy has not been done. So it's very important that aplastic anemia diagnosis should be done on bone marrow aspiration as well as good bone marrow biopsy. So these all investigations they confirm that whether it is aplastic anemia or not. Then routine investigations like renal function test, liver function test, viral studies like hepatitis B, hepatitis C, HIV should be done at least. And then we look for cause of aplastic anemia. So for that we can do PNH study, we can do a stress cytogenetics, NGS for inherited marrow failure syndrome. If patient is more than 60, then we may have to do some myeloid gene panel on NGS or FISH for MDS to look for similar conditions like hypoplastic MDS or MDS. So these investigations are there to confirm the diagnosis of aplastic anemia as well as to look for cause of aplastic anemia. Then what
So
other questions? Yes, sir.
yeah, so very well said that patient should be investigated thoroughly before starting treatment. And Dr. Nitin Sood, so before we start treating patient, would you like to investigate other systems also like cardiac status, his endocrine status, his kidney status, liver status? So before starting treatment, specific therapy, how will you investigate for other system also?
Yeah, that's very important, sir, because the treatment is not benign. I mean, although it's a benign disorder, but the treatment can be tough for the patients. So it's important that everything else is working and the body is in good shape before we start the treatment. So the basic, there are two lines of therapy that hematologists follow for the treatment. One is the non-transplant treatment called ATG treatment. So ATG related treatment means that you'll have to give a highly immunosuppressive drug to a patient who's already immunosuppressed. And so it's important that we rule out all sorts of infections, especially chest, urinary infections. And if there are any fevers ongoing, we make sure that that is properly investigated and treated before we can start immunosuppressive therapy. Because remember, the immunosuppression is going to go on for quite some time. Um, the other important type of treatment is bone marrow transplant or stem cell transplant, as we call it nowadays. And that means that we'll have to give chemoimmunotherapy sometimes to eradicate the existing diseased bone marrow, which also makes patients very immunosuppressive. So it's important we investigate the heart, the lungs, the kidneys, and the other organs in great detail, so that we know that the patient is strong enough to receive the treatment. And if there are any problems, then we address them before we start immunochemotherapy, so that the side effects or the morbidity and mortality from the treatment can be reduced substantially.
So, Dr. Dr. Kasi Viswanath, my next question is, what are the challenges you face while explaining the patient, the diagnosis, the therapy, the expenses, and regarding supportive care? So, patient will need blood components in form of vexel, volume, single donor, platelet. So, what are the challenges and how do you explain to the patient all these challenges?
Yeah. Yeah, it's a good point to make sure that we explain the disease in detail with the patient and the family. Uh, Patient initially comes with very low hemoglobin, and we give a transfusion, 1 or 2 units of blood transfusion. The patient feels very well. They don't realize that the seriousness of this disease. Uh, in no time, such patients can become very sick because of very serious infection or a life-threatening bleed into the brain or into the gastrointestinal system. That is blood vomiting or blood profuse bleeding through the intestine in the form of blood in the stools or bleeding into the brain, which can be life-threatening. And infections, irrespective of whatever antibiotics we are going to give, may not clear the infection completely. So it is very important. The first challenge which we have is to convince the patient and the family that this disease needs immediate attention, and we should go for the best treatment based on the age and the eligibility of the patient and availability of a donor for a bone marrow transplant. As Dr. Nitin was saying that there are two major treatments. One is the ATG, other is the transplant. So we have to try to fit in all these discussions early, very early, about the nature of the disease, the prognosis. If we don't start treatment and do treatment very early, we may lose the patient. So this is the and making understand the problem to the patient and the family is the most important challenge we face. Second is the cost of the treatment. One treatment is ATG, other is bone marrow transplant. So both are expensive. ATG treatment, the drug itself cost about 5 to 5 lakhs for a patient. Similarly, allogenic bone marrow transplant is also a expensive treatment. So we have to counsel them to the appropriate treatment and make avail various funds from various government institutions or places where transplant is being done under the support of the government also. All these things has to be discussed, and so one is making sure what is the diagnosis that has to be explained to them, the family and the patient in detail. That is the first challenge. Second is the arranging the finances for the treatment.
So, very well said. It is very important once we have the diagnosis, then to convince the patient and patient family for the treatment, which is a most of the time it can be a curative treatment, except in elderly patients where we treat patients with symptomatic therapy or supportive care only, or maybe with not with the intent of cure. So, Dr. Avinash Singh, what do you think the role of family or emotional support for these patients? How important it is, and how do you counsel the family for the this disease?
Yes, sir. So it's very important for as far as the plastic anemia or similar serious hematological disorders are concerned. And a plastic anemia has different challenge. As a hematologist, we face that many a times, as Dr. Kasi has said, that family or patient they don't understand the seriousness of disease, and that becomes difficult because after transfusing some blood or platelets, people feel that they are okay, they don't have problem. But this disease can have serious consequences. So I always explain to family that by the time you will understand that it's a serious disease, time has gone. So it's very important that you should become serious. You should take it seriously and move forward. Regarding motivation or to reduce stress, it's important. And in our society, people live in uh, extended family relations. So everyone comes to help them. That is good thing in our country, in our state where we practice. So they all share the problem, and by that time, this is the way that stress is less. But as the treatment modalities, the curative or definitive treatment modalities are costly, so finance is a very major problem that they have to face. So we have to take help from uh, their extended family members, then NGO, government help. So this is the thing. And blood donation is also a very significant problem in our state where I practice as a hematologist. So I always encourage everyone. I myself donate every 3 months blood, and I always encourage everyone who is healthy, 18 to 65, to donate blood every 3 months because there is huge shortage of blood components. And I try to explain to them, to the family, that you should understand the thing well, the seriousness of disease, and then we have to fight with disease together. We all hospital healthcare workers, doctor, team of healthcare workers, they are with you in fight against aplastic anemia. And over time, when we have counseling sessions, sometimes the psychologists, they also help. We try to reduce the stress, and over time, when there is some definitive treatment, they see response, they see their patients recovering. And the very important is communication with the older patients who has undergone a stem cell transplant or who has received ATG and they had shown recovery. So I told the new patients family members to meet with the older patients, and when patient family they counsel other, then it becomes more easy to reduce the stress and to move forward. So this is the way I usually counsel.
I think for all of us, the important challenge is the blood components, availability of blood
Yes,
components.
yes, sir.
Patient of aplastic anemia will need blood components throughout his therapy. Even if we don't treat, only give supportive care, then only he needs all the blood components. So availability of safe blood components is the most important part. And I think, as you rightly said, we should encourage all the family members and everyone to donate blood, or for single donor platelet also they should be ready to donate. Otherwise, I always explain that blood is not produced in factory. So if you don't donate, then it won't be possible to treat patient or to give him a curative therapy. And that way it is possible to encourage them to donate the blood for their own patient. So I think the very important challenge in some part of our country, the availability of blood components is really a issue, and it is very difficult to treat without its support. That platelet count may go down below 10,000, 5,000, and if you don't get platelet at right time, patient may die because of bleeding, which is most unfortunate part in I think aplastic anemia patients. So many times patient they don't agree for the treatment in spite of explaining them that this is the treatment and this is how we should go forward. But still, if they don't agree, then how do you face Dr. Nitin Sood? Then how, what extra measures you try to explain them, or what do you do at that time?
I mean, sir, it's it's always important to understand what's at the bottom of the reason for not agreeing for treatment. I mean, everybody may have a different reason for not agreeing, and it's usually ignorance. It's usually not understanding the severity of the disease. So it's important that whoever has a diagnosis, such a serious diagnosis, I always tell them that it's okay to be upset or angry or depressed, anxious, but talk to someone. Talk to either your doctor, your counselor, family members, even a psychiatrist if you need to. And if that doesn't solve your problem, then take some medicines that might calm you down. It's usually also important that the patients are very well informed. So there are several sources of information nowadays. You can go to the internet, you can go to AI. There's several medical, non-medical literature. There's YouTube programs like these which raise awareness, which tell you that if you don't get treatment, how serious the disease can be. And just because that aplastic anemia is not cancer, it doesn't mean it's not a serious problem. It's aplastic anemia. We know that has a very high rate of mortality if not treated. Um, if we don't treat aplastic anemia, then about there's only a 25% survival at the end of 2 years. So for a young patient, that really is a big problem. The other problem obviously might be the cost of treatment or lack of understanding about the treatment. As doctors, it's also our responsibility to explore various ways in which the cost can be reduced for the patient. So, we explore various CSR opportunities, government funding, insurance, panel, and things like that, where we can offer the patient some relief from the burden of treatment. Um, so, I mean, talk to someone like Dr. Avinash said, very nicely explained that talk to previous patients if you have to. And just as doctors, we have to understand what's the bottom of what lies at the bottom of this rejection to treatment. Once you can identify the reason for that, then it's much easier to deal with that.
So it is difficult situation sometimes when relatives and patients they don't are not ready to accept the treatment because they think that in spite of spending money and in spite of doing everything they may not get the best result, and so that's why we have to show them the cured patients after ATG therapy or after transplantation. So in that way we sometimes able to convince them for going for further treatment. So Dr. Kasi, we know that in our country finance is the major issue. So in your state or where you practice, what other financial resources are available from the government scheme, from NGOs? What other resource sources are there other than the patient's own financial resource? And how do you manage the patient who cannot afford all this therapy?
Yeah.
I think Dr. Kasi, can you answer Dr. Avinash? You can answer the same question. We'll go to
Yes, sir.
Kasi
Yes, sir.
afterward.
Yes, sir. So in our state, sir, for hematopoietic stem cell transplant match sibling donor, state government support with 4 to 5 lakhs
Hello.
rupees. Yes, Dr. Kasi, you can continue. Yes, Dr.
Yeah.
Kasi.
Hello.
Do you,
Am I
Yes,
audible?
yeah.
sir. Yes, you are
Yeah,
audible.
audible now. You you heard my question, Dr. Kasi? No, again yes.
Okay. So
Hello, Dr. Kasi.
in
Yeah, Dr. Avinash, you can go on now.
yes, sir.
I will ask
Yes,
him
sir. So
later
in
on.
our yes, sir. In our state for hematopoietic stem cell transplant, state government support with 4 to 5 lakhs rupees. So that is one CM relief fund we get. And for supportive care, sometimes they give 70 to 80,000 rupees. That is the help from state government we get. And many a times when we have to give ATG, Bharat Serum helps us by giving some free sample, like 10% to 20% number of vials as free. So that reduces the overall cost of ATG. That is one thing. They also sometimes support with CO level cyclosporin tablet. So these are help we are getting. That's all, sir. That's all help we get. Otherwise, family has to arrange funds.
Dr. Nitin Sood, you are practicing in a corporate hospital. So, do you get patients who can partially afford, and then how do you manage if patient can afford some part of the therapy and some part? Do you have other resources?
Yeah, well, it's very hard with aplastic anemia because both the treatments that are curative, like the ATG, is expensive, and the transplant is even more expensive. So the help that we can sometimes get is support from the pharma companies to reduce the cost of the medicine, as Dr. Avinash already said. I mean, some patients, about 20-25% of our patients are insured. So insurance is a big help in such situations. A lot of our patients have they're covered by various panels like the central government health scheme, the ex-servicemen scheme by the army, and we have a lot of patients who are covered by Delhi or Haryana government. So it makes it relatively easy to treat those patients because they're going to get sort of reimbursement. But there's this small minority which may not be covered by any scheme or any insurance where they have to self pay. In that case, we get help from the CSR initiative. So we have several agencies. I mean, unfortunately, the cancer charities can't help us because it's a non-cancerous condition.
Yeah, that is a
But
very
there are several CSR agencies that can help us, and they partially fund the treatment. So some of the treatment has to be arranged by the patient, or some of the funds have to be arranged by the patient. But these CSR organizations then step in and help out.
So, Dr. Kasim, my question was those patients who cannot afford, what other sources you use from government
Yeah.
or from NGOs?
Yes, sir.
Yeah, so that
Yeah, from the government, we get help, sir, from Tamil Nadu government, especially for transplant, even a full matched or a haploidentical or a unrelated donor transplant also, the Tamil Nadu government supports. So that's a good thing. For ATG, the government is not supporting. So we use other NGO support and pharma support, as Dr. Nitin and Dr. Avinash was saying, where we get subsidized medicines, so that will help them. So it's a big challenge, especially in a place where I am practicing. It's a second tier city, and the people come all over from smaller villages. Many times, financial constraints are a major hurdle. So initially, to buy time, we start them on the oral drugs, and once they make up their decision and make up their money, or they take time to arrange the finances, so till then we continue oral drugs and supportive therapy.
so I think when there is a will, there is a way. I think most of us, because we know that anemia is a curable condition, and particularly in young patients, it can be cured either with immunosuppressive therapy or transplantation, including haplotransplant. So I think all the doctors find their way, government support all other way to ultimately give this treatment, which is very important because it's a curative therapy. As we all know that if a match sibling transplant is done, almost 80-90% patient can be cured. With ATG, also 60-70% patient can be cured. So it is very important, and that's why we are doing this program to create awareness that this is a curable condition, and if treatment is given in time, most of the patient can be cured from such a serious disease. So my last question to all three panelists is, how do you manage elderly aplastic anemia patients, and what difference it makes in elderly patients? And elderly means more than 70 years. You can answer one by one. That will be the last question, I think.
Shall I start, sir?
Yeah.
Yeah. So basically, we have to understand what the patient needs and the family needs of the patient, whether they can afford the treatment. If they can't afford, probably not push into treatment like ATG. Just give supportive therapy, and oral drugs like danazol and cyclosporin and L-Trombopac can be given along with supportive care. If the patient is very fit and does not have any infection or major organ dysfunction like serious cardiac dysfunction or liver or kidney disease, we can consider ATG as a upfront treatment for this elderly population with aplastic anemia. Yeah.
Yeah. Dr. Nitin Sood, what is your approach to very elderly patients with?
Yeah, I mean the elderly, I think usually benefit from supportive care, which every patient needs anyway. But the elderly would benefit with blood transfusions, platelet transfusions, with a slightly lower threshold of hemoglobin, to make sure that they don't suffer from the consequences of aplastic anemia. I mean, we could still consider low intensity therapies like cyclosporin and now eltrombopag, which are drugs which are used to sort of semi treat the aplastic anemia with low response rates. But more importantly, they have very little complications. So they can be used. Then sometimes we can use anabolic steroids or immune modulating agents to lessen the impact of aplastic anemia on the body. And of course, supportive care always continues with things like blood transfusions, platelet transfusions, sometimes agents that can push the bone marrow to make more hemoglobin, or tablets or injections which can push the bone marrow to make more platelets. Of course, treating the infections and making sure that they don't have as much complications from the disease as they would have had without the treatment.
Yes, Dr.
Yes,
Avinash,
sir. Yes,
few.
sir. So for elderly, sir, aim is good quality of life rather than cure. So best supportive care, cyclosporine, danazole, L-Trombopac. These are the drugs that we try, and we usually try to give them for 2 to 3 months. If there is no response, patient is very severe aplastic anemia, then we can think of ATG. But we try to have good quality of life rather than cure in elderly populations. I do agree with Dr. Kasi and Dr. Nitin.
Yeah, so I think very elderly patients they need more of a palliative care rather than a curative therapy, just to make their life more easy with blood components and maybe cyclosporine and thrombopoietic agents. So I think we'll end the discussion here, and I will just summarize that aplastic anemia is a rare disorder, but it is a serious condition, and patient usually present with anemia, thrombocytopenia, with fever or with bleeding, or and uh, maybe severe tiredness due to anemia, and this should be investigated thoroughly. And the curable causes like of pancytopenia, like B12 deficiency or viral infection, should be ruled out. And for that, we have to do bone marrow aspiration and prefined biopsy both, and ultimately to do all the genetic tests to rule out congenital aplastic anemia, because the treatment modality is different for both. In acquired aplastic anemia, we can treat with immunosuppressive therapy and transplantation, while congenital aplastic anemia can be cured only by transplantation. So up to 30 to 40 years of age, we should do genetic testing to rule out congenital cause of aplastic anemia, and patient should be uh, counseled for the treatment, that it is a curative condition, and patient should be treated with specific therapy like immunosuppressive therapy or bone marrow transplantation. And family should be counseled for the therapy. For patient will need emotional support, financial support, everything, and they should be make aware that there are other sources of finance available if they cannot afford, and there are various agencies. Basically, if there is a will, we can find out the way, and younger patient should be given the specific therapy because it's a curative therapy. And elderly patients, as mentioned by everyone, that they should be treated with palliative therapy, and that quality of life should be improved till they survive with blood components and antibiotics and other supportive care therapy. So important thing is that earlier the diagnosis, earlier the treatment, and the outcome will be best. If patient has already taken multiple transfusions, then the outcome of immunosuppressive therapy as well as bone marrow transplantation will be poor. But if we do transplantation or immunosuppressive therapy within first 6 to 8 weeks of diagnosis, the outcome is very good, and most of the patients can be cured. So I think I will end here and give the stage to Bharat Serum if they want to say some concluding remarks. Dr. Nivedita, are you there? Hello. Anybody is there on the line from Bharat Serum? Hello. I think so. We can have a final two lines from every panelist regarding. So, Dr. Avinash, you can start final two or three lines for aplastic anemia, whatever you want to say, final words.
Yes, sir. So aplastic anemia is a serious disease, but it has curative treatment. So don't waste time. Have faith and move forward. Follow your hematologist advice and don't waste time. It's very important.
Yeah, Dr. Kasi, your final words.
Yes, sir. Aplastic anemia, as we have discussed, is a serious disease. We have to start treatment as soon as possible. Younger age, we should go for the best treatment, either the transplant or immunosuppressive therapy. We should arrange finances, the family and the doctor and the team should work together and try to achieve a cure in such patients.
Dr. Nitin,
Yes, sir.
your final.
Very well said by Dr. Avinash and Dr. Kasi. The only thing to add is make sure you don't live in denial. It's a serious problem. Start treatment as soon as possible. Talk to people, be well informed, and make sure that everything goes in. Just talk to your doctor and, to get some timely treatment.
So I think we can end the discussion here because I think there are no any other points. If you have anybody can have any other point if which we are not discussed, you can just tell because I think 2-3 minutes are still there. So any point if you think that we have missed in the discussion, then you can tell. I think
Sir,
most of the yeah.
Ayushman has any facility for a plastic anemia treatment? Ayushman scheme.
Yes, in Gujarat we have budget. Ayushman is for immunosuppressive therapy as well as for allogenic transplantation. It's a 7 lakh budget. 7 lakh for
Okay.
yeah. So we get 7 lakhs for transplantation and 5 lakhs for immunosuppressive therapy. So most of our patients get the specific therapy under Ayushman. The only problem is if we don't have the match sibling donor, then it is very difficult to manage within 7 lakhs haplo transplant, or it is impossible to manage match unrelated donor transplant because they have to pay 10 lakhs to the registry itself. So mud is not option in Ayushman. Haplo is very difficult. They need some other support also. But match sibling transplant, I think, can easily manage under Ayushman. At least in Gujarat, that is the position.
Yes, sir. And I think, sir, in India, we should have some Indian Aplastic Anemia Foundation like thing where patients who are cured of a plastic anemia, they should become member. And we should have some place where newly diagnosed patients or family, they can learn from them, they can listen to them. So I think this is the high time we should have some foundation like where at least educative. It may not
Yeah,
be financial help or something like that, but it should be some education where patients who are cured, they will teach new patients that how important to don't waste time and follow doctor's advice and go for the curative treatment. So I think Bharat Serum and others, Voice of Health, they can help us in uh, having such a society or foundation.
yeah. Because if somebody is having cancer, he can get lot of help
Yes, sir.
from other fast. But aplastic anemia, sometimes it is very difficult because it is not cancer. So some of the packages are not available for cancer because it is not cancer, and to get donation also is difficult because to explain the disease is become a problem. If you say it is cancer, some the sympathy will be immediately there and
Yes,
ready
sir.
to do it. Yeah. So I think we can end here. I think nobody is there from Bharat Serum, so we can end the discussion here. Thank you very much, all the
Thank you
panelists.
so much. Thank you
Yeah,
so much, sir, for taking out your time and moderating the session in such a beautiful way. It was a very insightful session, and thank you to all the panelists for taking out time and joining the session. So, thank you, Dr. Sandeep. Thank you, Dr. Vinash. Thank you, Dr. Nitin, and thank you, Dr. Kashi. It was a very insightful session.
Thank you.
bye, goodbye,
Thank you.
Bye.
Thank you,
Bye.
everyone. Thanks. Bye.
Thank
Bye.
you. Good night.
and bye,
Bye.
Bye.
Bye. Thank you. Bye.
bye, bye.